So today I am going to tell you about the basic nomenclature or the basic terms that are used in pathology. What does anaplasia and aplasia mean? Anaplasia means when the cell reverses to its more immature form. Say for example, a cell has been differentiated and it has formed a different type of cells for a bone cell. But then because of any reason, mostly because of cancer, this mature cell regresses to its precursor state, that is that stem-like state. This means that the cancer is really high grade, and the more immature it becomes, the more worst the prognosis is. That is anaplasia means. Aplasia means complete failure of the tissue or the organ. Aplasia, the tissue or the organ is not formed at all. So in DiGeorge syndrome, there is aplasia of the pharyngeal pouches. Therefore, there is missing thymus as well as the parathyroids, because there is aplasia of the third and the fourth pharyngeal pouches, which forms the parathyroid superior and the inferior as well as the thymus. Since parathyroids are not there, it presents with hypocalcemia. Thymus is absent, it presents with T cell deficiency. Prostate atrophy happens in those where post-orchidectomy. In prostatic cancer, to decrease the stimulation of prostatic growth by testosterone, testis is removed. That is, after orchidectomy, there is decreased testosterone which is released. There is decreased dihydrotestosterone. Dihydrotestosterone will stimulate the prostate. That doesn't happen. So this is known as prostate atrophy following the removal of testis. In testicular atrophy can also happen when the anabolic steroid use, that is, when testosterone is given externally, they are taking exogenous testosterone, then there is a negative feedback, thereby resulting in decreased LH and decreased testicular stimulation. So their testis can undergo atrophy when they are taking exogenous steroids. What about thyroid atrophy? When there is excess of T3, T4 thyroid supplementation is given, then in that case there is decreased TSH and there is decreased thyroid stimulation. Dysplasia is when the cellular atypia that precedes the cancer. That is, cancer shows abnormal morphology, but they aren't yet tumorigenic. The critical point over here is dysplasia is reversible. So in human papillomavirus induced squamous epithelial dysplasia, when they are in that stage, they haven't progressed to the cancer stage. So they are only in that squamous epithelial dysplastic stage. In that stage, spontaneous regression is possible. That is, dysplasia is reversible to a normal cell. What is hyperplasia? Hyperplasia is increased cell number. So hypertrophy happens when there is increased cell size. So endometrial hyperplasia is typical when the endometrial cells increase in number. When does this happen? In an ovulatory cycle, there is no ovulation. Only after ovulation, the corpus luteum will be formed, which will be releasing the progesterone. In an ovulatory cycle, since there is no ovulation, the uterus will be exposed to only the estrogen which is present with before ovulation. So only after ovulation the switch happens, that is, estrogen will stop and the progesterone will be released. But here, because of an ovulatory cycle, the uterus is or the endometrium is exposed to this estrogen which is unopposed. Who opposes the estrogen? The progesterone will oppose the estrogen, but there is no progesterone because the ovulation hasn't happened and the corpus luteum doesn't form. Therefore, this unopposed estrogen will cause endometrial hyperplasia, which can progress to endometrial carcinoma. Secondly, hyperplasia also happens in benign prostatic hyperplasia. When there is a lifetime exposure to dihydrotestosterone in older males, from around 15-17 years of age, they are exposed to the lifetime dihydrotestosterone. So the prostate keeps growing such that it will result in prostatic hyperplasia and it will cause obstruction of the the duct which passes through it and therefore presenting with urinary symptoms. The urethra will pass through it and that will be constricted, resulting in the urinary symptoms. So now what happens in hypertrophy? Hypertrophy is because of increased cell size. This can be because this can be seen in cardiac hypertrophy as well as in skeletal muscle hypertrophy. Cardiac hypertrophy can happen because of two reasons. If the afterload is high, that is when the pressure is high, it can result in a concentric hypertrophy. But when the preload is high, that is what the heart receives, when that is high, then it has to increase the space for the excess of the blood that it is receiving, which happens by eccentric hypertrophy. What is the difference between concentric and eccentric? In concentric hypertrophy, the cells are added in parallel. So the bulk of the cardiac tissue is increased. But whereas in increased preload, the cells are added in series. That is, the size is increased. The chamber size is increased. This is eccentric hypertrophy. Whereas in skeletal muscle, when there is resistance training, there is increased muscle fiber size and strength, again resulting in hypertrophy. What about metaplasia? Metaplasia is cellular transformation and it has nothing to do with metastasis or cancer. The normal esophagus is squamous epithelium. How will it be? It is non-keratinized, but it is a stratified squamous epithelium. Due to gastric acid exposure and reflux, that non-keratinized stratified squamous epithelium, that is the lower part of the esophagus, on continuous exposure to gastric acid, that can get converted to intestinal kind of cells. Pay attention, it doesn't get converted to gastric kind of cell. It gets converted to interstitial kind of cell. How will the intestinal cell be? The intestinal cell will be columnar epithelium with goblet cells. So, when the lower part of the esophagus, which contains a stratified squamous epithelium, gets converted into a columnar cell with goblet cells, then that is known as metaplasia. One mature cell type becomes another mature cell type. Now, if you ask me, is this reversible? It is. Both dysplasia as well as metaplasia is reversible. What do you know by neoplasia? Neoplasia is the term which is used with uncontrolled growth. So when there is a irreversible conversion to tumorigenic cells with uncontrolled growth potential, that is neoplasia. But neoplasia is not cancer. It can even be benign tumor. Benign tumors such as fibroadenoma, uterine fibroids are neoplastic, but they are not metastatic. So neoplasia can be benign cancer also. So benign and malignant both are called neoplasia. So, but there is only one exception, that is cervical intraepithelial neoplasia. It is technically dysplasia and it is reversible, but still its name includes neoplasia. So, long story short, dysplasia and metaplasia is reversible. Neoplasia, which includes both benign as well as malignant, is irreversible. The only exception is CIN, cervical intraepithelial neoplasia, which bears the name neoplasia, yet it is a dysplastic change which is reversible and not irreversible. That's all. Red neurons are seen as a result of acute ischemic injury in the CNS. They appear within 12 to 24 hours. This is much faster than in myocardial infarction, where histological changes are absent for several hours. Now, why do they appear pink? This is because the strong pink appearance of the neurons is due to protein denaturation and loss of RNA. Ischemia happens. ATP is depleted. ATP is needed for the sodium-potassium ATP pump to function. Now, sodium is not pumped out of the cell. Sodium stays within. Water enters inside and it causes cytotoxic edema. The ribosomes are lost. The cytoplasm loses the RNA, which will normally stain blue. The protein undergoes denaturation. cytoplasmic proteins will aggregate and they will bind the eosin strongly, giving the cytoplasm a bright pink appearance. The nucleus will become pycnotic, condensed, and eventually disappear. So all that which stains blue is lysed and disappeared, but the cytoplasm and its proteins which stains pink stays, and therefore the neurons after ischemic injury appears as red neurons. The CNS macrophages, that is a microglia, will phagocytose the debris, while the astrocytes will form scar formation or gliosis. What is Wallerian degeneration? The axon and the myelin degeneration distal to the injury site is known as Wallerian degeneration. Now, the regeneration will happen at a maximum of 1 millimeter per day. But the regeneration will happen only in the peripheral nervous system. In central nervous system, the regeneration doesn't happen because the Schwann cells in the peripheral nervous system, which can regenerate myelin, will function, and it will help the recovery possible, and that is the regeneration possible. But whereas the oligodendrocytes, which regenerates the myelin in the central nervous system, cannot do it effectively, thereby resulting in permanent damage in CNS. So even though the Wallerian degeneration means degeneration of the axon and the myelin distal to the injury, the regeneration which happens by the myelin growth happens only in the peripheral nervous system and not in central nervous system. This is because of the differences between Schwann cells and oligodendrocytes. That is the reason where the optic nerve in the CNS, which is regenerated by oligodendrocytes, doesn't get regenerated, and therefore optic nerve damage results in permanent blindness. While the other cranial nerves, which are a part of the peripheral nervous system, and the Schwann cells will regenerate the myelin with potential recovery. With this, we have come to the end of the presentation. I hope I have made certain concepts clear to you. Thank you for listening. All the best to whatever exams you are appearing.